Hello, today we're going to talk about maternal hemorrhage. So there are various reasons or various incidents that can cause hemorrhage during pregnancy. Okay, some of them we haven't listed here. We have an ectopic pregnancy. An ectopic pregnancy is basically when the egg is fertilized and implants outside of the uterus, such as in the fallopian tube. This happens in 95% of ectopic pregnancies where it implants in the fallopian tube. Then we have placental previa. Placental previa, it's basically when the placenta covers the cervix. It can be completely covering the os or partially, or it borders it. Okay, but we need to know that this causes or can cause hemorrhaging during pregnancy. Then, of course, we have abruption placenta, which is when the placenta separates from the wall of the uterus, resulting in vaginal bleeding. And of course, it interrupts the nutrients and oxygen supply to the baby. Then we have another reason for postpartum hemorrhaging or hemorrhaging during pregnancy is miscarriage or abortion. Okay, a miscarriage or abortion is basically the spontaneous loss of pregnancy before 20 weeks gestation. And we have uterine rupture. With a uterine rupture, this is most likely to occur in patients who do not have an intact uterus, meaning they've had a previous myomectomy or a previous cesarean section. Okay. Preterm labor is another reason for which we can find vaginal bleeding in a pregnant woman, but it is due to the cervical changes that are leading up to birth. This is a problem if it occurs before 37 weeks gestation. Okay. Then we also have an incompetent cervix. In an incompetent cervix, we find that the cervical os begins to dilate. It begins to open many times way before their 37 weeks, generally towards the end of the first trimester. Please note that vaginal examinations are contraindicated in all cases of unknown vaginal bleeding. All right, so we need to make sure that we first identify the cause for the vaginal bleeding, and then we can decide if it is prudent to do a vaginal examination or not. So let's talk a little more about ruptured or ectopic pregnancy. What are some of the signs and symptoms of an ectopic pregnancy, a ruptured ectopic pregnancy? You can have vaginal bleeding, and this doesn't necessarily happen 100% of the time. Sometimes the blood pools in the pelvic cavity and it does not exit via the vagina. With all ruptured ectopic pregnancies or even ectopic pregnancies, you're going to have abdominal pain, pelvic or abdominal pain. It's generally unilateral. Okay, they'll complain of lower abdominal pain either on the right or on the left, depending where the implantation occurred, if it was in the left or the right fallopian tube. They can also have referred shoulder pain. Okay, this occurs when the blood from the ruptured ectopic starts to pool in the pelvic cavity and it compresses the phrenic nerve and it causes referred shoulder pain. Obviously, if they're bleeding internally, you're going to find weakness, dizziness, or fainting. If bleeding progresses and we're not able to control it, you can eventually develop unstable vital signs, which are indicative of hypovolemia. Again, if hemorrhage is significant. How do we treat it? What are we going to do? How are we going to deal with an ectopic pregnancy? Surgical interventions, which I think we're all familiar with, and if necessary, blood transfusions. What are you as a nurse going to do? You have to make sure that your patient is stable cardiovascularly, okay? That she is hemodiluted, that she's well hydrated. You're going to establish access immediately. You definitely want to be offering explanations and reassurance to your patient and whoever is with her, if there's anybody with her, related to what's going on. Okay, because patients are in a difficult situation. They don't know what's going on. Many of the women that come into the ED with an ectopic pregnancy don't even know that they were pregnant. Okay, so they are processing a lot of information. They're finding out that they were pregnant, and they're also finding out that they're losing their baby. And in addition to that, they're in a high risk situation when they can, hemorrhage significantly and then get complicated from that. So you want to provide support related to the loss of their pregnancy, because even though they didn't know, it's very difficult for them to deal with the fact that that they're losing a pregnancy. If necessary, you want to administer ROGAM if it's indicated. If mom is Rh negative, we want to definitely administer ROGAM. QBL, quantification of blood loss, in every situation when we have bleeding is critical, okay? And we're going to talk later on in the PowerPoint as we go through this PowerPoint about QBL. But just keep that in mind that anytime somebody's hemorrhaging or, having vaginal bleeding, we want to make sure that we are measuring, that we are quantifying the blood loss. Discharge teaching for patients who have an ectopic pregnancy. You have to make sure that when you provide discharge teaching that you include pain management, that you refer them to different support groups, okay, that you discuss the different signs and symptoms to report. Excuse my typo there. The signs and symptoms such as bleeding, if they continue to have bleeding way more than expected, fever, severe abdominal pain, etc. Okay. Please note that another treatment that sometimes can be utilized in an ectopic pregnancy, not a ruptured ectopic pregnancy, if the diagnosis of an ectopic pregnancy is made prior to rupture or when it's relatively small, it may be managed with medication. The medication of choice is methotrexate, which can dissolve the pregnancy in a hemodynamically stable patient. So this treatment is not for women who actually have a ruptured ectopic, which is why it's not on my treatments here. But if the ectopic pregnancy is discovered before, it may be used. Then we have placental previa, okay? Like I said before, placenta previa is when the placenta is covering the os or obstructing the exit where the baby is supposed to be coming out. So what are some of the signs and symptoms that we're going to see that you as a nurse need to be able to identify? Okay, vaginal bleeding. It is generally painless. Most of the times it's bright red vaginal bleeding. It may lead to a hemorrhagic or hypovolemic shock. RH sensitization, of course. This is why we have to administer ROGAM if it's indicated, if she's Rh negative. You may find, if she's bleeding profusely, fetal heart rate changes. And depending on the amount of hemorrhage, it may lead to unstable vital signs in hypovolemia. What are some of the treatments? Please note, women with a previa will require a cesarean section for obvious reasons. As L&D nurses, you know this. Nearly all women with a low-lying placenta will also require a cesarean section. So even if it's not covering the os entirely, they will still require a C-section because the trauma that having a vaginal delivery would cause would just increase the hemorrhaging. And of course, anytime we have bleeding, blood transfusion is one of the possible treatments. You must confirm a previa with an ultrasound. Again, never do a vaginal examination on anybody who has vaginal bleeding for unknown reasons. Determine the fetal well-being and then anticipate that you are going to have a cesarean birth. Again, it depends on how much they're bleeding. Sometimes women with placenta previa will come into the hospital and they have some spotting post-coitus or whatever. Very, at the beginning, sometimes if they have no prenatal care, they might find that they don't know that they have a previa or a low-lying placenta. They have intercourse, they come in and they're spotting. Those women doesn't necessarily mean they're going to have a cesarean section then and there. If you can monitor them and notice that the bleeding has stopped, of course you would still have to do an ultrasound, then they can continue the pregnancy. Again, QBL, anytime they're bleeding, we want to be quantifying the blood loss. And then anticipate a blood transfusion. Okay. Please note one thing that I want you guys to know, that there is a significant amount of maternal blood flow to the placenta. So unresolved bleeding due to a previa or an abruption, which we're going to talk about in a little bit, can lead to maternal exsanguination. Okay. So a placenta abruption. We all know what this is, okay? The placenta is separating from the wall of the uterus. What are we going to see? Vaginal bleeding. Most of the times it's not bright red. It's like a darker red because it's coming from the fundus of the uterus. Sometimes it may not. It might be a little bit brighter. But bottom line, you're going to have vaginal bleeding. The abdomen, some of the telltale signs is the abdomen will become rigid. You will have hypertonic uterine contractions. What are hypertonic? It means they are severe contractions. Many times they are tetanic in nature. That means the contraction comes and it remains and it stays like that. The abdomen becomes very, very rigid and it is accompanied by severe abdominal pain. If the placenta abruption is a concealed abruption, you will find increasing abdominal girth. Okay, the blood will pool within the placenta, but you will see the abdominal girth increase. So this is something that we're going to see when a patient is having an abruption and she may not be experiencing any vaginal bleeding, but the rigid abdomen, the pain will be there. You may also find nausea and vomiting, decrease in renal output. Remember, when we're hemorrhaging, this is something that can happen. You can, again, all of this bleeding can lead to hemorrhagic and hypovolemic shock, RH sensitization, fetal heart rate changes. That's a huge one. If somebody is abrupting, you're definitely going to see it on the monitor. Okay, you're going to have a deceleration that is sustained. Okay, so they'll drop, let's say their baseline was 130, they can go down into very low 80s, 70s, and it'll be sustained. You have an obstetrical emergency. Okay, unstable vital signs and hypovolemia. What are some of the treatments? Cesarean section. This person we can't sit there and wait for her to deliver vaginally unless you are, okay, you can expedite a vaginal delivery if you are in the second stage of labor. Remember, the second stage of labor is when mom is complete and she's ready to push. If she's complete and you feel that, or you think, or the physician thinks that delivery is imminent, that she can do one push and the baby will come out, then you take your chances. Otherwise, you go into a stat cesarean section. Of course, you must anticipate that she might require a blood transfusion. You have to constantly be monitoring the baby. Fetal monitoring, checking, determining fetal well-being constantly, so she does not come off the monitor until delivery. Administer ROGAM if indicated. Again, QBL is crucial. Everything that she soaks up in blood with an abruption, you want to keep it so that you're able to weigh everything that she soils with blood. Anticipate the blood transfusion. Monitor maternal volume status and coagulation status, very important. Administer O2, okay. Restore blood loss with the transfusion, and again, continuous fetal monitoring unto delivery. Please note that some of the causes of an abruption can be drug use, okay, or trauma. Note that maternal death is rare, but it is 7 times higher than an overall maternal mortality rate. Okay, so yes, a patient that is not treated in a timely manner may not survive an abruption. Again, women can exsanguinate if they're bleeding heavily enough, anything that's related to the placenta, in as little as 10 minutes. So this is serious. Miscarriage or abortion, okay? A miscarriage is pretty much before they reach 20 weeks gestation. After 20 weeks, we call it an abortion. It's a spontaneous abortion, but we have to keep in mind that anytime that this happens, if somebody's having a miscarriage, again, below 20 weeks, you're going to find vaginal bleeding. They generally have uterine cramping and lower back pain or abdominal pain. Treatments: if the miscarriage is inevitable, the abortion is inevitable, then we can administer misoprostol, generally 800 mites, and of course surgical evacuation if there are any fetal remains or products of conception that are still in utero. Nursing interventions: you want to monitor their vital signs and bleeding. Again, QBL is critical. I can't stress that enough. And you want to administer ROGAM if necessary, if it's indicated. Provide psychological support for the patient and the family. With discharge instructions with these patients, make sure that you refer them to a support group and that you provide information on miscarriage and pregnancy loss. A lot of women will ask themselves the questions, why did this happen? Why did this happen? So, you want to make sure that you provide support. The other thing that I want to say, for those women who end up aborting, even if it was by choice. Please note that they grieve, okay, and that it is not your job to be judging anybody, that it is your job to provide psychological support for the patient and the family and refer them as needed. A uterine rupture, it's an obstetrical emergency, okay? This is most commonly associated with VBACs. The uterus has that has no surgical history, okay, and is spontaneously contracting. Spontaneously contracting meaning we're not using oxytocin or anything to stimulate contractions, is very unlikely to rupture. Therefore, please note, again, prevention is the best solution to everything, that we should avoid labor inductions. If we avoid them, we would substantially decrease the risk of uterine rupture. In mothers who are attempting a TOLAC, we do not use oxytocin. We don't use anything to stimulate their uterus to decrease the chances of them having a uterine rupture. Inappropriate use of oxytocin, please note this, is associated with uterine rupture. So you have to limit its use to achieving a labor pattern. Okay, and I know that this might come as a shock to several of you, but please note we utilize oxytocin to augment or induce, but it's not to be abused, basically, because excessive use of oxytocin can lead to a uterine rupture. And again, we definitely do not want to use these or any type of uteral tonic in patients who do not have an intact uterus. Now we're going to talk about postpartum hemorrhage. Okay, so this is different. So by definition, postpartum hemorrhage is blood loss or quantified blood loss of 1,000 mLs or more within the first 24 hours, not at the time of delivery. It's not just in the immediate postpartum setting. In a spontaneous vaginal delivery, it's more than 500 mLs of blood loss of QBL within the first 24 hours. Please note that postpartum hemorrhage is the leading cause of maternal morbidity and mortality in the United States. Okay, it is important to prevent postpartum hemorrhage. So how are we going to do this? We must assess and promote normal uterine involution. Please note that the uterus may be about 1 centimeter or 1 finger breadth above the umbilicus at 6 to 12 hours postpartum. And then it should be 1 centimeter below you or below the umbilicus at 24 hours postpartum, 2 centimeters at 48 hours postpartum, etc. Okay, when you are massaging the uterus to make sure that it is firm midline at umbilicus in that postpartum setting, make sure that you support the lower segment of the uterus to prevent a uterine inversion. Okay, nobody wants to be the guilty person for causing a uterine inversion. And it's very easy to prevent. You support the lower segment of the uterus by putting pressure in above the suprapubic area. Understand lochia and the presence of clots or placental tissue. Okay, this is important for you as a nurse to know, but more importantly for you to make sure that you educate your patients on monitoring their lochia. They need to know what scant looks like, and I have some pictures here, what a light amount looks like, what moderate amount looks like, and what a heavy amount looks like. If your patient is saturating a pad every hour, that is not normal. Okay, so we need to make sure that we are doing interventions constantly. We know that we are supposed to be assessing the uterus every 15 minutes during that first hour, the second hour every 30 minutes, and then after that every 4 hours. During the first 24 hours, we should be assessing. After the first 24 hours, we can assess Q shift. But the most important thing is that you educate your patients. Why? They're going to be your partners in preventing a hemorrhage. Okay, if you tell your patient, here, palpate your uterus, this is how it should feel, this is where it should be, and this is how your pad should look like. Let me know if it looks, like this, if it's heavily saturated. Okay, also we need to teach them that it is okay to touch their lochia, that clots can easily dissolve when they are touched. However, placental tissue will remain. You can't dissolve placental tissue, and if they find placental tissue in their lochia, they must report it. That is not normal. It can lead to hemorrhaging. Okay, you need to be able to palpate the bladder to make sure to see if there's any tenderness or for fullness. We know that when a patient is retaining urine, this can lead to hemorrhaging because the uterus becomes boggy. It displaces the uterus from the pelvic cavity. It becomes boggy. It's deviated generally to the right. And we, again, increases our chances of having a postpartum hemorrhage. And we don't want that. So we need to make sure that we are able to palpate. If they have tenderness, or you can palpate in the lower part of the abdomen, the bladder, then you need to know that some patients maybe are not voiding because either they're scared or because there's, swollen tissue in the area. And so you need to know what actions you have to take. Many times we have to not just provide pain meds, but also straight cath them to make sure that we are emptying the bladder. Okay, very important in the postpartum setting and even in LND that we know where our hemorrhage cart is, and we need to know what's in our cart. All right, please note that all the hemorrhage carts include a Bakri balloon. Right, sometimes the doctors will ask you for this and we don't know where to find it. It is in the hemorrhage cart in the labor room and in the OB floor. In addition to various things, saline solution, LR, IV kits, etc. Many times if your patient is bleeding, you're going to need more than one access, more than one IV access. Please note that it is important that we notify the appropriate personnel and that we document all the interventions taken. Again, prevention is everything. So what are the causes of postpartum hemorrhage? And I talked a little bit about some of them, but tone, okay, uterine atony due to a large baby, high parity, rapid labor, and fibroids, okay? These are the women that we need to keep our eyes peeled for. Why? Because they're more likely to hemorrhage in the postpartum setting. Okay, women who have macrosomic babies, it takes a lot more effort for the uterus to involute properly and to keep that tone. So, or when we have a precipitous delivery, a woman starts labor and she delivers in 20 minutes from the time she arrived. This is something that we need to monitor, okay, because it affects the tone. But more than the tone, she can have trauma, which can cause lacerations because of the speed at which she delivered the baby. The tissue, retained or abnormal placenta, we just talked about that. Again, important to educate our patients so that they know what normal lochia looks like. And if they have tissue that's coming out, that means they have retained placenta and it must be addressed. Trauma, lacerations, a hematoma. This can occur due to, a shoulder dystocia or just a difficult labor, okay? So we need to make sure that we monitor that. We need to make sure that the lacerations are being repaired and that there is no bleeding after a repair. If you have a patient who develops a hematoma, we need to monitor it because even though you're not going to see a saturated pad, the hematoma will grow and you need to assess your patient. Okay, that's the only way that you're going to be able to find it, and it needs to be addressed. And then thrombin disorders such as preeclampsia and stillbirth. We know thrombin disorders, of course, if your body is dissolving clots faster than it can form them, we have a problem, and we need to make sure that we are aware of that we know where our patients stand. That's why it's so important to make sure that we have labs before, as soon as they get into the hospital, as soon as they're admitted, that we have labs and we know where they're at with their PT, PTT, and INR. So what are the signs and symptoms that we're going to look out for? Slow and steady bleeding, okay, a little trickling. It's not always gushing, okay? Or large, boggy uterus. Firm uterus with continued bleeding. Okay, maybe she has a laceration that everybody missed. The uterus is firm midline, but she's still trickling blood. We need to make sure that we assess. Strings of tissue and large clots. Sudden onset of painful perineal pressure. This is when they have a hematoma. Bulging area just under the skin. Again, a hematoma. Difficulty voiding or sitting. Okay, if your patient is not voiding properly or she's not able to sit, you need to do some research and find out why. What is going on? Does she have a hematoma? How swollen is she? Is her bladder full? Is this going to cause more hemorrhaging, etc.? And of course, you need to be aware of signs and symptoms of DIC. Okay, is she oozing from IV sites? And I hope nobody ever has to witness this, because if you've allowed it to get to this point and you didn't notice that there was something wrong with your patient until they're oozing from IV sites, nosebleeds, petechiae, and they're hypotensive, we're in trouble at this point. Okay, you never, again, the key is to prevent this type of situation, and we prevent by making sure that we are monitoring. More importantly, your best partner is going to be your patient and the significant other, whoever is with them, that you educate your patient on how to monitor for some of these things. And of course, when you do labs, do they have normal lab values? And if not, we need to make sure that the doctor's aware that we're notifying people and that we are taking action to correct this. Treatments, resuscitation and management of obstetric hemorrhage and hypovolemic shock. Of course, identification and management of the underlying causes of hemorrhage. Is it a laceration? Is it a full bladder that's causing a boggy uterus? Is it a hematoma? What's going on? We need to identify that. And then know that where your uterotonics are. Medications, we're going to use Pitocin, Methergin, Hemabate, Misoprostol. Mechanical methods that we utilize, a lot of times the Bacri balloon, bimanual exam and fundal massage. Many times all you require is laceration repair. Sometimes we require a DNC. And in serious or severe cases where bleeding, where we're not able to stop the hemorrhage and we can't identify it, many times the doctor will decide to do a hysterectomy. You have to make sure that you have a large bore IV access, and if you don't have one, you need to make sure that you establish one. And if you have one, you might want two. Okay, IV hydration. We want to definitely make sure that our patients are well hydrated. Continuous monitoring of vital signs. Anticipate surgical intervention. Administer uterotonics as per policy and provider's prescription. Interventions are going to vary depending on the underlying cause of the hemorrhage. You must be familiar with hospital policy. Okay. It's important that we know the stages of hemorrhage, and I'm gonna show you a picture in a minute. Please know that a laminated algorithm is found on all hemorrhage cards. Okay, so you can find it there. And in addition to that, because a woman can hemorrhage even up to a month. She can experience postpartum hemorrhage even after a month of after having her baby. So she can go home and she might be fine under your care, and when she goes home a week later, she might hemorrhage. So we want to educate our patients. Okay, you don't want to send them home without knowing, which is why we are now giving that post-birth warning signs poster, which I'm also going to show you in a minute. Every single patient that goes home that you send home should have one of these. So these are the obstetric hemorrhage stages, 0 to 3. Okay, 0 to 3 is basically every woman who's giving birth, so on and so forth. Please make sure that you look in your code cards, in your hemorrhage cards, where you have this laminated. There is also a version of this in your policy, and we are going to briefly look at that as well. Please note that you must be familiar with policy 200-107 on maternal hemorrhage and 200-109 on massive OB hemorrhage. It is your responsibility. I want you guys to know that you can find copies of all the policies, not only this maternal hemorrhaging, but all the policies on the under the policy and procedures icon on the desktops of all computers in the unit. Please make sure that you take a minute and that you go to your desktop and look for these. Note that you're responsible for knowing or being familiar with all these policies. We don't expect you to memorize them, but note that if during an inspection or at any time, if anybody asks, that when in doubt, that you know where to access these policies so that you are following the hospital policies and procedures to make sure that we are providing standard, efficient care for our patients, and that you are doing what you are required to do as a nurse at Hialeah Hospital. So this algorithm is part of the policy 200.109, and you should be familiar with this. I urge you to please go onto that icon and look for this policy and study this, because it tells you how you are going to manage the different cases of hemorrhaging depending on the stage that your patient is in. What is expected of you? Okay, and I'm not going to go over everything because you have access to it and you can look at it. Again, I urge you to please do this, to take a look at this. QBL. QBL. Again, prevention is the best intervention. QBL is quantification of blood loss, and it is hospital policy. Compliance with QBL, 100% compliance with QBL is mandatory across tenet. Okay, what are we looking for? What are we concerned with? The idea is that we want to make sure that our patients who are post-cesarean section are not losing more than 1,000 ml of blood after cesarean section within the first 24 hours, or more than 500 ml in a spontaneous vaginal delivery. Please note, for those of you who are in postpartum, that we should be documenting if a patient lost, let's say in a C-section, 800 cc's, that in the postpartum setting, until she reaches those first 24 hours, that we should document cumulative blood loss. Okay, should be recorded on the patient's chart until the patient is physiologically stable. And that can take anywhere from 2 to 24 hours post delivery of the baby. These are some of the frequently encountered clinical concerns and responses. People might think that QBL is a waste of time. Some people think that it doesn't apply to their patients or their demographics. Some people might think that it takes too much time to do, or that you can't do it. What we need to think is of the amount of time that will be saved if we avoid a hemorrhage event. Okay, so you guys can take a look at these. Providers believe that their patients are unique and that research doesn't apply to their specific group of patients. These are the responses that A1 has. Distribute key peer-reviewed literature related to the measurement of blood loss to every nurse and physician. Many physicians and nurses have only performed EBL. Okay, they're not familiar with how to quantify blood loss. And this is a big issue. We do have in labor and delivery and in the ORs the scales so that you're able to weigh all the soiled items. You do have a list of dry weight versus soiled or soaked weight, so you can easily calculate it and then document it on Cerner, on your EHR. So please take a look at this. Please note that once you get into the groove of doing this and it becomes part of your routine, it does not take a lot of time. It is minimal. Is it perfect? Is it exact? No, it's not. It is not precise. Okay, however, it is definitely more accurate than EBL, and contrary to what some might think, which is that QBL is going to be very high. You know, we have found that when you weigh the soiled items, the laps and the blankets and socks and whatever gets soiled, that when we quantify the blood, it's generally, you know, we have found that many times it's less than what we think it'll be. Uterotonics, okay, these are our go-tos when we're dealing with a patient who is hemorrhaging. And we're all familiar with oxytocin, methergin, carboprost or hemabate, misoprostol, and tranexamic acid. I know that in the hospital, Hialeah, we really don't use it. We do have it. It's available. Most doctors usually, you know, address this with the 1, 2, 3, and 4. Oxytocin, methergin, carboprost, and misoprostol, which we have in our units, in our omnicells. You need to know how to access that. Okay, so oxytocin is basically our first line of defense as a uterine stimulant. At doses greater than 40 units, it'll be likely to be ineffective and may lead to hyponatremia. Please take note of that. Methergin, okay, should never be given IV. Please note that. Methergin is generally given intramuscularly at 0.2 milligrams every 2 to 4 hours, depending on prescriber or provider orders. Should not be given in the presence of hypertension. Caution should be used If multiple doses of ephedrine by the anesthesiologist have been used, because it may cause an exaggerated response to methogen with possible cerebral hemorrhage. So you need to look out for that. Hemabate or carboprost. The dosage is generally 250 mites intramuscularly or intramyometrial. So it can be injected directly into the myometrium, may be repeated at 15 to 90-minute intervals for a maximum of 8 doses, all right, or a total of 2 milligrams in 24 hours. You never give Hemabate IV. Cytotec or misoprostol, we administer 800 mites to 1,000 mites via the rectum. Cytotec really has no contraindications, but it's unlikely to produce an effect if Hemabate has failed. Okay? Tranexamic acid or TXA is an inhibitor of fibrinolysis. It is not a first-line treatment. It's most effective when given within 3 hours of hemorrhage diagnosis. Hence, the recommendation that it be considered relatively early in the hemorrhage protocol. Okay, I don't think we have this in our hemorrhage protocol, but it's good for you guys to know that this is something that exists, that it is out there. Again, we want to give it within the first 3 hours since the identification of a postpartum hemorrhage. And it is not our first line treatment. IV administration, okay, the TXA solution for IV use contains 100 milligrams per ml and can be used as a slow injection or diluted with a 50 to 100 ml IV piggyback to be given as an IV infusion. To avoid hypotension, administer at a rate not to exceed 100 milligrams per minute or 1 gram over 10 minutes. It must be prepared the same day the solution is to be used, so it's not something we can have pre-mixed. Discard any remaining solution after single use. It may be mixed with most solutions for infusion, such as electrolyte, carbohydrate, amino acid, etc. Do not add heparin to injection or mix it with blood. Can't mix it with those fluids. Okay, don't mix with solutions containing penicillin. You need to, again, know and be sure that you know where these medications, these uterotonics are. It's also important that when you are putting in orders or checking your orders, that you know that you have postpartum hemorrhage standing orders for your patients. Okay, and this is just a table showing different things to consider when utilizing these medications. Okay, so with oxytocin, it's IV infusion, generally continuous. Usually there's no side effects, but it may cause nausea, vomiting, hyponatremia, or water intoxication. Again, that's why we don't want to give more than 40 units. Prolonged IV administration decreases blood pressure and increases heart rate with high dose, especially if it's IV push. It's contraindicated only if you have hypersensitivity to the drug. Methergen, again, contraindicated in hypertension, PAH, heart disease, or hypersensitivity to the drug. And like I said, if multiple doses of ephedrine have been given by anesthesia, you must be careful with that. Hemabate, you have to caution in women with hepatic disease or asthma, hypertension, active cardiac or pulmonary disease, or hypersensitivity to the drug. And then Cytotec, just if you have hypersensitivity to the drug itself. This is the flyer that we are required to give to our patients upon discharge, right? And it's basically giving them information on the things that they should be reporting. Okay, call 911 if you have pain in your chest, if you have obstructed breathing of shortness of breath, if they're seizing, obviously. And then thoughts of hurting yourself or someone else. Okay, and then call your healthcare provider if you have bleeding soaking through 1 pad an hour, or if you have blood clots the size of an egg or bigger, if your incision is not healing, if you have red or swollen leg that is painful or warm to the touch, temperature, if you have a fever, if you have a headache that doesn't get better even after taking medicine, or a bad headache with vision changes. Okay, these things, this post-birth, I don't even know what it is, it's an acronym. These warning signs can save your patient's life, all right? They need to go home with this. They need to be, it's not just putting it in the packet and sending them home. It's making sure that you discuss it with your patients and that they know what this means. Okay? Very, very important that we do that and that every patient gets one of those. And we're briefly going to talk about massive transfusion protocol. So let's say we have a patient who starts hemorrhaging and it gets to the point where you're required to initiate a massive transfusion protocol. What is a massive transfusion? Okay, it's not giving 1 or 2 units or 3 units, even if you're giving them back to back. That's not what that is. Massive transfusion is basically the replacement of the recipient's total blood volume within 24 hours. Okay? Massive transfusion protocol, basically, we have a protocol in place to ensure that we have standard and efficient delivery of blood and blood products to our patients. All right, please reference policy 11 and 14 called Massive Transfusion Protocol. It was created by the clinical laboratory or blood bank. And again, you are responsible for knowing this, being familiar with this policy, and at a minimum, knowing that you can go to your desktop, look for the policy and procedures icon, and search for this particular policy. What you need to know about the policy, since we're talking about it, you must, if you require blood or you're initiating a massive transfusion protocol, you must notify blood bank at 4853, extension 4853. You must then fax the transfusion consent and provider orders with the words MTP number 1, massive transfusion protocol number 1, written on the form, and you must fax that to extension 4222. All right. If your patient, let's say they came in and they were having an abruption because they had got into a car accident, they came in and they're hemorrhaging as they walked into your unit, and they have not been type and crossed, you must sign or fill out an emergency release form. Okay, and uncrossed blood will be initiated. Uncrossed matched blood will be initiated. In the massive transfusion protocol number 1, section 8, it says that the blood bank is going to dispense 2 units of O negative packed red blood cells within 15 minutes of the protocol initiation. They'll also provide 1 dose of platelets. This is not 1 unit. This is 6 to 10 units, which is basically what a patient needs. Please note that Hialeah only stocks 1 adult dose of platelets at all times, okay? And 2 units of AB fresh frozen plasma in a cooler with a temperature indicator or monitoring device will be sent up, okay? So you'll have fresh frozen plasma. This usually takes about 45 minutes from the time of initiation because they have to thaw out the plasma. But you will get your platelets and you will get your 2 units of packed red blood cells. And you want to make sure that at that moment that you initiate it, that you're drawing blood so that you can send it to the lab to be typed and crossed, all right? So the massive transfusion protocol 1 part B, the nursing staff states that the nursing staff has to notify blood bank to process additional emergency release products if it's required before compatibility tests are completed. So let's say you go through those 2 units and everything that you're administered and you need more blood, you must notify them, okay? And the blood bank will send another 2 units and more AB fresh frozen plasma within 45 minutes of the call. Once the client has been cross-matched, then they'll stop sending O negative and will start sending type-specific packed red blood cells and FFP. If your patient has already been cross-matched at the time that you initiate the MTP, then you follow the same process, okay? You call the blood bank, you give them a call and let them know, and you fax the information. The difference is that they are going to provide you with 3 units of type-specific PRBCs or packed red blood cells, 1 dose of platelets. Remember, Hialeah only holds 1 that will be ready, and then two within 15 minutes, and then the 2 fresh frozen plasmas, which will be ready within 45 minutes of the initiation of the MTP number 1. All right. If the doctor decides to continue an MTP, you have to send again a copy of the provider's orders with the word MTP number 2, words MTP number 2 written on the form, to be faxed again to 4222 after you have called blood bank at 4853, placing the orders on the computer. Okay? So I urge you to please read this policy on massive transfusion. When you go pick up the blood products from blood bank, you have to bring a patient label with a wristband sticker. If you don't have that, you can write, but let's say the patient ran out or they fell off, but you have the number, the BBID number, you can write it on the form as long as it matches what blood bank has, and you attach it to the transfusion order form during downtime, or make sure that you document it when you place your orders on the computer. If you don't have this, then you just bring a patient label if you have one, and put the orders in the computer. You also require the signature of the responsible RN picking up upon use. So whoever goes to pick up has to sign. Upon completion of a massive transfusion protocol, the nurse is responsible for calling blood bank at 4853 and notifying them that they are stopping or completing or discontinuing the massive blood transfusion protocol. And you must fax a copy of the emergency release forms signed by the provider. And again, fax it to 4222. This is just information on the different blood products, the considerations and advantages. Again, when you see here the FFP, the reason why blood bank takes 45 minutes to send it to you is because it's kept frozen, hence the name, but they have to thaw it out before they can release it to you. Platelets, again, it's very important that we know that we only hold enough platelets for one person, for one MTP event. If they release them for an MTP event, then they will call one blood and request more platelets. Cryoprecipitate also takes 35 to 45 minutes because it is kept frozen and it has to be thawed for release. Please note that this is reserved for women with fibrinogen levels of less than 80. 10-unit pack typically raises fibrinogen 80 to 100 milligrams per deciliter. Caution, this is important. 10 units come from 10 different donors, so your infection risk is proportionate. I just listed here for your knowledge the policies and procedures related to postpartum hemorrhage and hemorrhaging and pregnancy. So we have a policy on abruption placenta, emergency C-section, emergency equipment, OB rapid response, because if you do have a hemorrhage, these are some of the things that you're going to have to know how we handle it. Maternal hemorrhage, maternal obstetric hemorrhage, massive obstetric hemorrhage, pharmacologic treatment of postpartum hemorrhage, and then guidelines for implementation of OB early warning signs and QBL. Please, I urge you to go onto that icon that we have on the desktop and all the units and all the hospital computers and look for all of these policies. You don't have to print them out. You can email them to yourself. You can read them whenever you have a little bit of time, and be familiar with them because you are responsible. Remember that when you abide by hospital policy and procedures, the hospital will back you up, okay? You are supported by the policies and procedures. Now, documentation. Okay, it is very important that we know where to document anything related to hemorrhage. And like I keep on saying, prevention is the best intervention. So it's important that when we assess a patient as they're coming in, when we're admitting them to our unit, that we assess them for the risk factors of having a hemorrhage event under our care. You need to know where this is documented, all right? You can go into the labor and delivery section, and then you have a little thing that says hemorrhage VTE risk assessment, and you can document it there, all right? And I know that most of you, at least those of you in L&D and in OB, are familiar with this. This is where we assess whether they are low hemorrhage risk, medium, or high hemorrhage risk, right? We need to make sure that this is completed upon admission to our hospital, to our units, even if it's just for triage, okay? Because a triage patient may become an admitted patient. Therefore, this needs to be completed. And this is done at the very, very beginning, right? If I have a patient who I know has a placenta previa, okay, that's a red flag right there. I can mark it here under high hemorrhage risk factor. And I know that this is a patient that I have to monitor closely for hemorrhage because she's a high risk, okay? If they have a known coagulopathy, if they have active bleeding, or if we have a suspected placenta accreta, percreta, or increta, if their platelet count is less than 100,000, okay, et cetera, et cetera. These are things that will give you a great idea on how you should be managing your patient. Please note, this must be completed. It is a requirement. QBL documentation. We know where to find this under delivery blood loss. And this makes it really easy. If you just enter the weight of saturated amounts, the weight of the dried items, it'll give you the net blood loss, QBL, the net quantified blood loss, all right? Please make sure that you know where to document this on Cerner. Again, I urge you to review the QBL policy and that you know how to use the tools, that you know how to weigh all the soiled items, and that you know where that form with the dry weight is. I believe there's a laminated one with the scales, but in addition to that, you have a folder with blank sheets so that you can write on it and then transcribe that onto the EHR. Again, guys, if we make this part of our daily practice, every time that you have a vaginal delivery, if you make it part of your process, you don't even have to think about it. It just is. So then again, different places, those of you who are in postpartum, you can continue. If you have a patient who's maybe saturating pads or bleeding a little bit more than you're comfortable with or than they should be, please make sure that you continue documenting the blood loss. All right, remember, hemorrhaging is more than 1,000 in a 24-hour period, or if post C-section, or more than 500 mLs in a 24-hour period. Okay, so it doesn't stop when they leave the labor and delivery unit. Vaginal packing. Sometimes a patient has a laceration or something and the physician puts vaginal packing. We need to make sure that we know where to document that they have vaginal packing, or that the physician in your presence put in a vaginal packing. When it's removed, all right, this can also be found in patients post-hysterectomy. So we need to be aware of that. We have to make sure that the patient has a band. And then when the vaginal packing is removed, we need to make sure that the removal of the vaginal packing is documented and the band is removed from the patient. And last but not least, this is just something that was given to us, and it basically shows you how the maternal mortality rates are on the rise in the United States. If you look at every other country, it's decreasing. In the United States, it has increased, which is honestly unacceptable because we are a developed country. We have more resources than most of these countries. So we just need to do everything that we can to make sure that we bring this number down. Please note the Joint Commission perinatal safety standards will be heavily focused on maternal hemorrhage effective January. And the new standards are aimed to reduce harm related to maternal hemorrhage and severe hypertension and preeclampsia, which we will be reviewing on a different class. You will receive, after you have completed this class or this video, after you've watched this video, your assistant manager, your manager, somebody in the unit will be handing to you a quiz. And you must get an 80% on that quiz to get credit for this education. Okay? Thank you.